So welcome to the third video for our comprehensive exam preparation session, in which I'm going to talk about qualitative research as specific to the field of health policy. So what do you know so far about how policy decisions are made? At this point in your education, it's probably a very complex question. You're thinking about interests, institutions, ideas. You're thinking about path dependency and policy entrepreneurs and windows of opportunity and all kinds of evidence and political factors, and it can be overwhelming. I think we could all agree that policy decisions aren't just about evidence. There are all kinds of other forms of information that play a role in how problems are framed, solutions are proposed, chosen, and implemented. We increasingly recognize the importance of social, cultural, and political and human factors in these decisions, and that's where qualitative research can come in. These social, human, and cultural factors impact the acceptability of proposed solutions, the transferability of solutions from one context to another, and the implementation and persuasion of the importance of these solutions to different groups. This is where qualitative research really shines. It can help identify the interplay between these factors, the contextual issues, and the gaps between what we know and what we need to know. Qualitative evidence can be useful to decision makers, and it can also be used to study the process of decision making. So here's a little heuristic to think about the types of evidence that qualitative research might contribute to health policy decision making. So first, we could think about qualitative research as eliciting descriptive evidence about what issues exist or what relevant experiences are there. And second, we could think about qualitative research as offering some normative or values-based advice about what the decision makers should do or how they should think about these issues. In this video, I'm going to provide you with two different examples of how I've used qualitative research to inform health policy decisions. If you'd like to learn more about some general principles about qualitative research and health policy, here's a couple of resources. Um, the JAC reading should be on Avenue, as should the introductory chapter from the Murphy and Dingwall book, although I do find this book a little bit dated because the field, including decision makers, I think have moved beyond the skepticism of qualitative evidence that's, I don't know, kind of pervasive in this introductory chapter. Okay, so I'm going to provide you two examples. The first will be how qualitative research is used in health technology assessment. Health technology assessment is very structured, so there's clear ways in which qualitative research can fit in, a variety of accepted methods, and increasingly routinized procedures for conducting reviews and syntheses of qualitative research. The second example, I'm going to share a recently completed project that involved primary empirical case study commissioned by the College of Family Physicians of Canada. This was more ad hoc responsive project to the questions that the college had, and we didn't have a variety of frameworks or methods to rely upon. Okay, so first, what is health technology assessment? According to the WHO, HTA refers to the systematic evaluation of the properties, effects, and impacts of health technology. It's a multidisciplinary process to evaluate the social, economic, organizational, and ethical issues of a health intervention or health technology. The main purpose of conducting an assessment is to inform policy decision-making, usually about the funding, and then sometimes about the implementation of a particular technology. So what can qualitative research contribute to health technology assessment? Most typically, qualitative research is used to identify social values, potential ethical issues, and to contribute patient perspectives, especially from hard-to-reach populations. There are a bunch of different ways that qualitative researchers might be involved within an HTA. Sometimes qualitative research is used as part of an ethics analysis. Sometimes we conduct a review of qualitative research that exists to provide patient perspectives. Sometimes qualitative techniques are used in patient involvement, so direct engagement with patients. And so occasionally this turns into sort of a primary qualitative study within the context of the HTA. The contributions of qualitative research to this field include providing evidence about social, psychological, ethical, and organizational assessments. They also can provide contextual information to help understand how the technology is understood, implemented, or used by particular groups, and can also inform the value judgments that need to be made within an HTA, such as scoping or defining boundaries around the technology or determining appropriate outcomes and metrics. So what information is available? There's a large body of qualitative research in the social sciences that addresses issues relevant to patient-centered care. And these are often sort of high-level general papers about, for instance, experiences of illness in healthcare, lay understandings of health and illness, preferences for healthcare, or patient-defined aspects relevant to the process and the outcome of care. This empirical and theoretical research can also draw attention to the potential social and ethical issues. They can highlight perspectives or interests that are not yet included in the evaluation, or groups that might benefit or be disadvantaged from an intervention, or sort of elicit public opinions about controversial issues, or raise these to the consideration of the committee. Most of the time that I've done qualitative research for HTA has been in the context of synthesizing existing evidence, existing qualitative evidence about patient perspectives, typically relevant to the condition or the disease that's related to the device or the technology that's being studied, because there's often not qualitative research that's directly relevant to the device or to the technology itself. So for instance, I participated in a health technology assessment of pancreatic islet cell transplantation, which is a surgical transplant that can be done for people who have unstable type 1 diabetes. And we couldn't identify any qualitative research that was particularly about this pancreatic islet cell transplant. And so instead, we synthesized research about what it was like to live with uncontrolled type 1 diabetes. So the second example comes from the CFPC, the College of Family Physicians of Canada. So we have a couple of papers under review right now, so they're not publicly available, but the report directly to the college is available online. So this was a request that the college put out. They put out a request for proposal where they have these certificates of added competence that they run, and they wanted to better understand their impact. And what the certificates of added competence are they're a formal means of recognizing enhanced areas of expertise achieved and maintained by some family physicians. So in 2018, the CFPC released a request for proposals to help them understand the impact of this program. In particular, they identified a policy question related to the future of the CAC program, including a need to understand the desirability of additional CACs. They have a number of CACs, but this RFP was particularly interested in 4. Family physicians who have enhanced practice in care of the elderly, in family practice anesthesia, in palliative care, and in sport and exercise medicine. There's an older and highly politicized CAC in emergency medicine that was explicitly excluded. And then there was also a few very new CACs in 2018 that were excluded because they just didn't think that they had been sort of diffused well enough. So the objectives of the project that we undertook, we did a primary qualitative research project to inform the policy questions of the CAC in terms of how they could develop a way to profile family physicians who hold CACs and to understand the impact and the influence of this CAC program on a number of things, including the provision and outcomes of comprehensive community-based care, the members of the CFPC, so family physicians, and also trainee decisions and learning profiles. Finally, they wanted to determine the risks and benefits of introducing more CACs. So what we did was we conducted a mixed methods multiple case study in a variety of different phases. So first we worked with the college and with regional representatives that they identified to really understand what their questions were and what their priorities, so that we could design a case study that would elicit data that would be useful to them. Second, we conducted 3 exploratory case studies and did cross-case analysis. And then when we had a theory developed about what was sort of going on with these CACs, we conducted a couple more explanatory case studies to confirm or to refine those findings. And then finally, we did a pan-Canadian survey that was more quantitative to be able to comment on the generalizability of the findings that we had from our qualitative work. So this is sort of a complicated diagram that shows how we moved from the exploratory cases into the explanatory cases, and also details the sort of the complicated aspect of this was that within our cases, which we defined as particular groups of family physicians who are working together, we could look at all the different domains of the CAC. So we could look at palliative care, anesthesia, sport and exercise medicine, and care of the elderly within a particular practice group. And then down at the bottom in the blue, we had our final outcomes, which were our report to the CFPC, which is we've transformed into a peer-reviewed manuscript that's currently under review. And then now we're also working on individual papers relevant to each of the domains. So for this case study, we conducted we had 6 cases across the country, and I've removed the geographical markers from this map because I know that I'm going to put this video on YouTube. But we made sure that these cases represented a mix of urban, rural, and remote locations, academic and non-academic, and that they were various sort of distances to tertiary care, had differing levels of resources. So the benefits of qualitative research for answering these policy questions were that they allowed us to provide context. So the CAC program is very diverse, and the case study approach allowed us to accommodate the diversity of both the program and of family medicine practice. The context-based approach permitted us to look at CACs in various types of family medicine practice arrangements in different jurisdictions and with different patient populations and resources. By pairing our qualitative case study with a nationwide survey, we were able to test some of the propositions that we developed during the case study phase, which allowed us to offer some thoughts on the generalizability of our qualitative findings. Some of the drawbacks. So by doing a qualitative case study, we weren't able to comment on the financial implications of CACs or care outcomes or anything that would need to be quantified. We didn't aim to produce findings which were generalizable to all family physicians. We can't assure that. So by choosing cases that represented a bunch of different practice arrangements and jurisdictions, we hoped that we would be able to identify some findings or some lessons that were sort of higher level and consistent across these variable settings, but of course, we can't make any conclusions beyond the groups that we did research. Where is the work now? So after we produced the report, we sort of went back and forth with the college where they would read it. They'd have more questions. We need more information on this. Present it to different stakeholders within the college who would have more questions. More requests for information or for conclusions. And so I think that type of process is really one of the most valuable parts for the policy makers, where they get to look at the information that's there and then say, okay, what about this? Or what does that mean? Or how should we interpret this in relation to this other issue? And then there's this sort of iterative back and forth with the researchers who can go take those questions, look at the data, and then try to offer some more concrete conclusions. And this sort of process of presenting to various committees and being available to answer questions or conduct additional analyses is, I think, really essential to the process of doing research in conjunction with policymakers. And it's quite different from how things go in other realms of qualitative research, where you translate your knowledge often in a more unidirectional way, sort of publish your paper, you make your education materials or whatever it's going to be, put them out there in the universe, and then see what happens. And that's it for this video.